Okay.
We are connect now. Good to go, sir.
Yeah, okay. So thank you. So good evening, doctors. During this current difficult condition of lockdown and social disconnect due to COVID-19 outbreak, digital connect is in the form of live web streaming is the best platform to disseminate scientific knowledge. I, Dr. Kishore Sankusare, medical advisor on the behalf of Ultima Division, INTAS, welcome you all on this live streaming on survival strategy for small and medium-sized hospital in current situation. To chair this session, I would like to invite Dr. Vijay Agrawal, who is a pediatrician by profession and currently working as a president of consortium of accredited healthcare organization. Over the last decades, being a pediatrician of his repute, he has played an important role in improving the healthcare system in India. He has played a key important role in national programs like Pulse Polio program, and also he has introduced centralized waste management system in Delhi. This program has far reach impact and he's continued to leverage his expertise as an excellent organizer, strategist, administrator, and presently championing the cause of patient safety and enhancing the quality of healthcare delivery. So I request Dr. Vijay Agrawal to take over the session and request all of you, the listeners, to kindly drop your questions in the comment box, which can be discussed at the end of the session. Thank you. Happy learning. Over to you, Dr. Agrawal, sir.
Thank you, Dr. Kishore.
Welcome, sir.
And dear friends, we are passing through a difficult time. To say that will be, I think, an understatement. Today, I think every individual, every family, every community, every city, and every state, and then the whole country is fighting for survival and is looking at the strategy, how do we survive? And therefore, it is not something that was to be unexpected, that the small and the medium hospitals should be looking at the survival strategies for this segment of healthcare. I think the small and the medium hospitals should have been looking, they were looking at survival strategy even pre-COVID era. And this issue has, I think, taken much more center stage at this time. For sure, I think the things are going to change for good. It is not something that we expect that things will be absolutely hunky-dory in another 4 weeks or 6 weeks time. And then who knows that when this virus goes, another virus will not come, and so on and so forth. So I think the medical profession has to gear itself to face the kind of scenarios which have been presented by this present pandemic. And to that, at the moment, I think we have to look at the leadership. It is at this kind of time when I would say the test of leadership will be there. And therefore, to listen to this survival strategies for the small and medium hospitals, I think we could not have found a better person than Dr. Naveen Chitkara. I have known Dr. Naveen Chitkara as not only as a neurosurgeon of repute, he is also a great, I would say, technology expert, and he's also an entrepreneur. So he's like a real, I would say, multifaceted person, graduate, postgraduate from Rohtak Medical College and other institutions within this country and abroad, and is a recipient of, I think, many awards, including the D.L. Shah Award for 2 consecutive years and many other awards. I will not like to keep on talking about it, otherwise will not leave much time for him to speak about the topic. So over to you, Naveen, and please enlighten us about the survival strategies.
Thank you, sir. It was such a nice presentation for me, sir. I have done most of the learning about all these things from your side only. And whatever I do today is what I have seen you doing as a leader in so many things. The times are not good. To start with, this slide is not good. So I have shown dawn from here, because whatever we are going to talk about today may appear a bit pessimistic, but we have to understand that we are in a situation, and this whole talk is about that how to get out of the situation. It is not about to discuss what is wrong and with this, but it is how we can utilize this to improve and improvise ourselves. It's like having opportunity in this type of times. As you rightly said, we watch television news and we get scared. We read some WhatsApp messages, we get scared. The situation is actually critical. It is critical for us to survive. We have to understand that virus is here to stay. The economy is at its worst, and it is going to change our life to a new normal. Whatever we used to live was something like our life one, then there is an interval, and there will be a life two. Now, whatever changes we have in our lifestyle will have a great impact on our healthcare delivery. So that is what we will be discussing today. The crisis in healthcare sector is going to last for months. The liquidity effects would there be, which will be there beyond weeks and months. Then we will discuss whether we will be getting some help from the government or not, what needs to be done. So all these things that we'll discuss in the next 40-45 minutes. But to get the feel of the situation of the healthcare where we are in the current times, I would just take next 3 or 4 minutes to just highlight certain points where the current situation globally is.
Naveen, your slides are not on.
Yes, sir. Your slides, you haven't shared your screen, sir. Slides is not shared.
I'll do it again.
Yes.
I'll do it again. Yes. So do you get it now?
Yeah, now it's clear, sir. Yeah.
Okay. So the summary for the topic would be that we have to talk about the revival. That is, we have to get our patients and business back, and survival also, because how to survive in these tough times and get our patients back to work ethically, professionally, take care of the patients, the healthcare workers, the support staff, and how we go back to the family. Everything has become important today. Slides are not moving forward, so let's see. So as I said, that initial 3 or 4 minutes I'll take about the situation. The situation is critical. We know about BC and AC, but I have labeled it differently, like it is before Corona and life after Corona. So we have to learn to embrace the virus. It has got some economic aspects and it will change the lifestyle. We all talk about flattening the curve. We have to understand that flattening the curve is just to limit the number of cases where the healthcare is not overwhelmed. No government will be able to eradicate this virus from our lives in next couple of months. And the life is not going to ease out till the time we have a vaccine available or there is herd immunity which develops. I was talking to one of my friends in US. He said that before 9/11, there was a phobia. After 9/11, that whenever they used to sit in an aeroplane, they would always be scared that the person sitting next to them might be carrying a bomb. Similarly, a few months down the line, there'll be a phobia that we will be scared of the person whom we are meeting or who is sitting with us or who is talking to us might be a COVID carrier. I say no confidence. Fast forward yourself to say April 2020. You want to, like we are holding a webinar here, you want to go to a conference to a central place like Delhi. First, you will have to convince yourself that actually you want to attend it. Then there will be deterrents from the family who would say, why do you want to go it? You will have to choose a safe transport, where you are staying, what is the hotel like, all these things actually will shake your confidence and you might decide not to go to that conference. Similarly, in organizing and attending the social functions and gathering, going to social gatherings would again be the same. So it is the worst crisis since the Great Depression in 1930s. There is a contraction of global GDP. In the great financial crisis, the contraction of global GDP was to the tune of 0.1%. And it is predicted that by this year end, the global GDP would shrink by 3%, which means over 30 times. And if the pandemic goes still further, it might shrink to up to 6%. So there'll be a shift to low touch economy. Why I'm talking about this economy is because eventually the money which is there in the market with the people, the free money, is going to decrease. There'll be a new globalization. And this globalization would be where that people would socialize, meet, do business, everything on internet, and there'll be very limited movements all around. The discretionary spending would decrease, the ticket size would decrease, and people would want to spend on things which are very cost effective and which are value for money. So we have to re-ready ourselves for the new world, and there have to be some long-term measures which are to be linked to reducing the cost. Now coming to the healthcare. So there will be changes in healthcare, there is crisis in healthcare, and there will be liquidity crisis also. So pre-COVID areas, pre-COVID times, almost 80% of beds and 60% of patients, the treatment was provided by the private healthcare. Everyone used to think that private hospitals, they make good amount of money and they are sitting on hoards of money. But the fact was that the economies were fragile. There was low EBITDA. This is the times I am talking about before this COVID hit us. The cash balances to meet the expenditures, they were low. And in a study, it was found that on an average, a cash flow of 19 days was there with the hospitals to meet all the expenditures. That was an average. The hospitals, they are highly capital intensive. And if we do an audit of all the expenditures that are done, you will find that almost 80% of the costs cannot be shrunk, and they are almost the fixed costs. This is the famous David Goliath. The small hospitals, medium-sized hospitals, they have always been fighting with the corporates because to survive, they have to provide similar services, but the cost has to be low, and it was already getting difficult for these hospitals to survive in front of the corporate hospitals. And now this was an unhealthy sign. This slide I presented in January sometimes. For last 1 year, 200 smaller and medium-sized hospitals, they closed in Andhra. Small hospitals, they vanished in Kerala. Hospitals for sale and lease, there were many. And this was true for all parts of the country and around the world also. But still, the doctors, they seem to be comfortable because we used to overwork, we multitasked, we did not delink ourselves from the institution, we had rotations of the earnings, and we did not save for the crisis situation. We never planned for a retirement. We wanted to work as if we would never die. And we did not live the life we should have lived as a human being. Compromised and compensated, we did on many things. And if that was a comfortable scenario, which was pre-COVID, what is going to come now? So in post-COVID areas in healthcare, we have to presume that all patients, attendants, visitors, and healthcare workers are positive, even though they are asymptomatic. The current situation is that in many of the hospitals, there is a decrease in footfalls to up to 70% in OPD and overall. Fall in investigations to up to 80 to 90%. This is a pessimistic scenario, but then we have to discuss if we have to take the talk forward. There's a fall in occupancy to 30% or less. We have to make ourselves pandemic ready. Now, this I'll discuss in the next slide. What is this additional thing meant to us? We have to treat and manage as if all patients are positive. There is an increase in the operating cost. There are depleted cash balances. We have difficulty in paying salaries. We have paid it for the last month, for next month, and for next few months. If the situation stays that grim, it will be difficult to have all those salaries being paid easily. Less revenue is expected due to less disposable income, as I discussed earlier, less employment, and we will have, because the travel would be much lesser, so we'll have less overseas patients. And there will be a negative return on the capital. But for how long this is going to stay, we do not know. We can predict by certain analysis till what time the virus is going to stay, till what time the endemicity or pandemicity of the virus is going to stay. But till what time this impact will last on the healthcare sector, we still do not know. Now, this is pandemic ready. As soon as we were hit by the COVID, we rushed to purchase the PPEs. That was to save us and to save the healthcare workers in our organizations. Disinfection and prevention of spread activities started, which again took some cost. We had to invest in manpower, disposables, consumables, equipment, and infrastructure for preparedness. The staff was getting sick, so manpower losses were there. Wage inflation was there. We had to incentivize the staff salaries to keep them on payrolls and to come and to stay coming to the hospital, and increased retainers over there. We had to stock extra inventory because in last 1 month we never knew what was going to happen, so we had to keep so many things in hand so that the hospital keeps on running. And extra cost was incurred on maintaining the workforce. Now, with this all situations in healthcare, pre-COVID and what we faced in last 1 month or so, 1.5 months or so, we thought about that, will there be something coming from the government? Actually, the government has expectations from us. They want us to test the patients in private sector at a cost which the government has decided. They want us to treat the COVID patients also, which is now a situation happening in metros like Delhi and Bombay. And in addition, we have to continue the treatment of non-COVID patients. And this all has to happen in a scenario where we do not know which patient is positive, which visitor is positive, which attendant is positive, which healthcare worker is positive, and we have to treat as if all patients are COVID positive. There were many medical organizations who had discussion with government, and they wanted some tax benefits or ESI or PF to be waived off for a couple of months, some concession loans, outstanding dues to be AHPI, Dr. Gyani and Dr. Vijay Agarwal, they worked on that outstanding bills from CGHS, ECHS, they are paid to the hospitals, and waiving of electric and so forth. These were all our demand. But if you ask me, this is what is going to happen. We are drowning. The government gives you a helping hand which says you are a hero and you drown. So we have to work for ourselves and not look at the government. If they do something for us, that's very good. But if we are very optimistic about all these things, we have to keep our fingers crossed. Yesterday, when we put this topic of webinar on circulation, few of my friends from different cities, they called me about what I'm going to talk about. They said that in multiple of their groups, the doctors are already talking about shutting their hospitals till the time the things settle, because they cannot give the salaries beyond certain time. So that was one option which was told to me, that many of the doctors want to shut. Or you could just work in piecemeal, limiting your services and limiting to whatever patients you want to get. But what we are going to talk today is to accept this challenge, because we have to accept that the virus is going to stay with us. And all the things that we discussed about the changes in healthcare system which are going to come to us, they are going to stay. So we have to work our way around that. There's a statement, when offshore, that is the time when fisherman repairs his nets. But now is the time when, in addition to repairing the net, we have to add sails to our boat, and we have to make it more dynamic so that it runs or delivers more than what it used to deliver before. This is a time when we have got a lean season, when we have got a lean period, we are preparing ourselves for the COVID. This is the time when we have to we have to understand our processes. We have to see what was wrong in that. We have to improvise on that so that we strengthen our work profiles. We work on the worker safety and be more efficient, which will be the key. But the most cardinal would be enthusing confidence. So revival is getting the patients back, and survival is how to survive in these tough times that I have discussed earlier. So as I said, that this all is about fighting back and remembering that almost 80% of the cost cannot be shrunk. So I have divided this into 4 things: increasing business, increase in confidence, decreasing the expenditure, and the COVID expenditure. Now, to draw the patients back, as I said earlier, the confidence is the most cardinal thing. We need to have the confidence of the patient. I give you an example. You used to travel Lufthansa, for example, or Cathay Pacific, which were very good branded airlines. And in 6 months down the line, they start functioning as usual. But there's no distancing between the seats, so they are taking their passengers on the similar types of economy seats that they used to take earlier. Whereas Kingfisher, which is a doomed airline, or SpiceJet, or some other airlines, they do a good homework. They, right from the point of entry to the airport, they maintain social distancing for the travelers. The seats are managed or allotted in such a way that there is an adequate distance between the two travelers. Which airline would you want to travel? Of course, the airline which is providing you social distancing or adequate distancing. So this is what is all about brand loyalty. There might be patients who were very loyal to you. They would be coming to you, and the families would be coming to you in all those times. But if you do not change in recent times, you would not get their confidence, and those patients will not come back to you. So that is the most important and the cardinal thing which I would say, that in coming times, if you want to revive your business, you have to think in the lines of what a patient would be thinking about in terms of his health and his health safety. So you have to, right from the point of entry to your hospital till the time the patient sees you, the prescription is handed over to him, the pharmacy prescription is managed. You have to organize how the patient moves in a distance where the crowding is less and the patient goes home in a good confidence. Similarly, if you want to get patients from TPAs, the tie-ups have to have, they should have confidence that all their clients will be managed properly as they used to be managed before, and this social distancing and all these things will be managed adequately. Plus, if you want to add to the volumes of the income, then you have to think about other factors which are associated, like you have to think about more about preventive medicine and vaccination, all these things added onto the hospital so that the incomes flows they increase. Now, increase in the confidence. Now, as I said earlier, that building confidence in the patient is going to be the most important thing if you want to get the patients to come back to you. I go to the awareness part first. We talked about, I was a part of NABH before, Dr. Agarwal and all of these senior people who are associated with NABH. We had to push a lot about to create awareness about NABH in the public so that people would understand which is a hospital which would provide a certain standard of treatment, and there is standardization in that particular hospital. Lots of energy would have gone in at that time. But this is the time when people are already aware of COVID, they are already aware of social distancing, they are already aware of personal hygiene in terms of washing hands, masks, use of masks and protective shields and all those things. So the awareness is already there. So this is the time when if a patient has to choose, he would want to choose a hospital which is safe for him. He would want to choose a OPD which is safe to him. He would want to choose a nursing home which is safe for him. So the awareness is already there. We have to build confidence, and this is like all precautions need to be taken. There will be hand washing corners from parking to visitors to appointment, teleservices, e-medicine, the telemedicine things, and all these things need to be there in your setup so as to build confidence. Now, the worker who is associated with you, either he is a staff nurse, he or she is a staff nurse, or any category, including the consultant, they should have a confidence in you that your hospital is thinking about their safety. Because if they feel secure and safe in your hospital, that will be the thing which will help them work with full dedication in your hospital. Now, this is a slide which I took from one of the leadership programs. This says what was the causes of deaths in healthcare worker in last 1.5 months. So the hospitals need to know what is what is not good for their healthcare workers, what is bad, what is going to cause increase in the infection rates, what is going to cause increase in the mortality. So all these factors need to be taken care of so that the workers, they are confident about their safety within the hospitals and they will get the best and the maximum to the hospital. Now, the next is about decreasing the expenditure. So this topic we had discussed earlier before the COVID era also. But now is the time when we need to strengthen our structures so that the expenditure decreases. As I said, 80% cannot be decreased. So we have to work around 20%, but we can work around that 80% also, so that we can just lean out our system to what minimum needs to be spent has to be spent. Earlier, there used to be two types of setter: larger with good reserves, so they had good cash flow with them, and they would spend money. They could spend money for maybe 2 months, 3 months without holding a salary or something. And there would be smaller setups or single person owned setups where the extra money which was earned during the healthier times would be disinvested, not in the which would be disinvested from the hospital for their personal properties or personal buyings and would not be reinvested into the hospital. Now this mindset has to change. So the smaller hospitals where you would just take your income back home and utilize them for your personal expenditure, you will have to keep something safe for the wrong times, and you will have to reinvest in the hospital so that it gives you back during these times. So lean management is not a certification, but it is a mindset of a commitment to achieve a totally waste-free operation that is focused on maintaining patient satisfaction, which is important. Cutting costs does not mean that you cut on the patient satisfaction level. So this has to maintain as it was earlier also, but it is achieved by simplifying and continuously improving, and so that all the processes are strengthened and there is no compromising the value. So this is what you have to practice in your hospital. A person, if he becomes sedentary, tends to gain weight. Similarly, when an institution gets old, it tends to gain fat. And this fat in the hospital is in the form of useless waste, variability, and unnecessary strain. So this is, in general, the combination of all the things that happen over a period of time in the hospital, and this needs to be shrugged off now. So this extra fat has to go down. So all these things, intellect, failure to fully utilize the time and talent of people, usually employ people just for the sake of employing and not actually looking at their usefulness, overdoing unnecessary movements that does not add value. There are many errors, pilferages are there. And because the coffer is already, it has got good amount of money, so you're not actually looking at what wrong is happening. Process variations are there, unnecessary transportation, unnecessary inventory storage is there, and unnecessary waiting. So these are things which need to shut off, which need to be shut off now. Now, decreasing in spending and overview. So we will analyze about HR, clinical department services, support service, and common services in a few moments. But we have to be thoughtful on what we are spending. Capital and inventory buying. Earlier, I am a neurosurgeon. I work on a microscope which costs me around 35 lakh rupees. It has got good optics. It has got very good magnification and zoom factor, and I do all my surgeries in that. Whereas one of my contemporaries, when he was opening his hospital, he just went by a status buying for all the equipment. He bought a microscope which was worth 1.5 crore rupees. Now, once we are spending in capital or on inventory buying, we need to be careful that whatever we buy, either it has to improve the results or it has to somehow increase the incoming of the money. If your investment in inventory or capital is not doing that, we should resist from spending on those things. Decrease movements. In all processes of the hospitals, you would see that there can be certain amount of automation or certain amount of transfer of information through computers which can happen, and that can decrease the cost. So this is where you have to just think about what is happening in your hospital and just try to work on things where you have to spend and where you don't have to spend. Similarly, the ambulances, they would be traveling here and there just to pick up some food, to pick up some staff. So these all things you have to analyze what is happening in your hospital. Printing costs, they, although they appear to be very small, but when added, they add to a good amount. And there are certain stationaries which are printed and not used. So you have to just think, analyze what you need to print more. Pharmacy and inventory, we have lots of stocks in the hospital. One of a visiting consultant comes to the hospital, he orders a strip of tablets and the pharmacy buys 100 or 1000 of those tablets. So what is coming in needs to be invented. We need to have some scientific method to organize how inventories are stored. We have to organize a method in our hospital, a scientific method where the commonly used or the most frequently consumed items are stocked in larger numbers, whereas those which are required less are stocked in a lesser number. So this inventory management in a scientific way has to come in, because this is something where we can save a lot. Expenditure audit should be done by your institution once in every month. I'll come to this point in a few slides later, but this is going to tell you where you should be spending and where you should not be spending. And you should also analyze that if few of your services can be outsourced or not. If the costing comes out to be lesser, if you are outsourcing some of these services, you should go with outsourcing. See, the ultimate aim is that the patient's flow should come back to the number which it was before COVID era. And because of the situation where you are presuming that all these patients are COVID positive, you have to manage all those patients in the hospital also. Now, if I talk about the different components of the hospital which work from bringing in patients, so it is your branding and marketing team. You have got an expenditure for this particular activity. Now you have to see if you have to change to electronic or a digital platform to save money on that. Similarly, if you are managing your TPA panel patients, you have to look for an electronic or a digital platform which can save you cost in managing administrative part of these patients. Each hospital has got consultants who would be either type of consultant who would have the foot following. So when they join your hospital, they bring patients with them. And there would be certain consultants who are on salary. The owners of the hospitals have to decide which method suits them, whether if the consultants on salary, what modality of percentage sharing they have to do so that they are not shelling in money beyond what a consultant is bringing in. Then there is clinical team on which you have to spend, which is nurses and all these support teams which you have to spend on. There are services within the hospital like lab, radiology, pharmacy, and all these things which usually add to the contribution which contribute to the total income. And so this is directly linked to the number of patients which are flowing in. The support team like admin, HR, MRD, IT, maintenance, biomedical accounts. So these support teams we have to spend on these teams even if there is one patient or there are thousands of patients. So you have to work around which is the best method which is suited to you, how you want to make them work. Do you want outsourced services in any of these? You reorganize how lesser number of people can do more number of jobs, which can be done by revising or restating the job description, job profiles in your hospital. You have to see in the time of crisis how you can get the work done from minimum number of people. So this is a service-oriented industry. We cannot compromise on our clinical services. That is the bottom line. So whatever clinical services which are getting the patients into your hospital and maintaining good results has not to be compromised. The analysis of data is very important. As I said, the audit is to be done. When we talk to our accountants, they have a list of expenditures which would be alphabetically presented to us, and we are happy to just do a comparison of the different amounts spent in each month. Now is the time when you have to go into the details of that, the micromanagement. So besides a list of expenditures, you should be having a list of trends, like the number of OPDs, the number of IPDs, the number of ICU admissions, number of operations, and all these numbers you should have. And like in our hospital, I give you one example. We note the oxygen and the nitrous consumption. Now, we just came out with a observation that although the number of patients operated in our operation theater were the same, but the consumption of the nitrous oxide was almost trebled in last 1 year. Now, with this small observation, we could note that either there is less of the nitrous which is coming to us, or there is some leakage somewhere. So we did some changes and the expenditure came back with the same number of cylinders which was before we made this observation. So there could be hundreds of such things which need to be observed. And this can happen only if you are doing the calculation of the expenditure in addition to the comparison with the numbers. Your number of patients in the hospitals on ventilators should be sort of directly proportional to the amount of oxygen consumption. The amount of air conditioning being used should be sort of directly proportional to the electricity consumption. So these all things need to be evaluated and audited every month. Like in panel or TPA, you need to know what is the total amount of collection from the panel and TPA every month and what is the expenditure. So you know what is the profitability coming out of that. In addition to that, you can break up the data for all clinical department also. In my subsequent slide, I'll show you how you can do it. So that goes into still finer details of the micromanagement. But if you need to cut down cost on unexpected, unusual, and unwarranted expenditure, these are the things where you have to work on that. So the numbers, the collection, and the expenditure, three things you can have. So in our hospital, for example, we have got 20 different sheets which are doing analysis, cross analysis, and comparison between different things. So the OPD, OT, IPD, conversions, emergency, admissions, and all these numbers can be used. So the point about micromanagement is that you have to sit, if it is a single owner, he can sit with the accountant. If there are multiple owners, they can sit together. They have to first understand how they started and what is happening now in their hospital. They have to analyze where they are spending. They have to do a root cause analysis of every small thing where each number and each amount spent matters. A comparison is done between two. Then they have to adapt and adopt. So they have to change their ways, how they are spending. They have to adopt it themselves. They have to make their healthcare workers, their associates, their colleagues learn what is the new change in the hospital, and ensure that everyone adheres to this change system where the expenditure is less and is accounted, and you can account for every penny which is spent in the hospital. So this is like the clinical department-wise expenditure. So area, energy, professionals, admin, housekeeping, AMC, CMC, maintenance, capital, recon, consumer. So these are all the heads where the expenditure can be done in one clinical department. So this is exclusive spending in that particular department, where it is shared by other department, and the expenditure where it is shared with other hospital, and the expenditure which is done on IT, finance, MRD, CSSD, for example, about the support department. So once you get into the habit of all these things, you will come to know about how profitable your ICUs are, how profitable your each clinical department is, how profitable your services departments are. And support departments, of course, they have to be there, but they have to be managed in a deep way. So coming to the COVID expenditure. Now what has happened is that when we started with our new forms of hospital, we had to buy so many things on PPEs, and in our hospital, the cost suddenly shot up in the last 1 month or so. So now is the time when you have to just sit and decide about, because see, the virus is going to stay with us. As I said, all the patients, you have to presume that even they are tested PCR positive or KIT negative or PCR negative, you have to consider them to be positive. So you have to try to find out a solution for your particular hospital in a way where how you want to do it, but you have to take care of. See, buying PPEs, disposable PPEs, changed by every staff in every shift at each location, it might not be possible. So you have to try to find out solutions which are affordable, which are sustainable in your hospital, and which are reproducible in your hospital. And if some of your friends or your colleagues, they want to reproduce it in their hospital, they should be able to do it. Similar would be that you get some ideas from your colleagues to implement in your hospital. Because this is an added expenditure on PPE, so you need to choose which is the best and the appropriate PPE for a particular area depending upon the exposure of the patients. If you can reuse certain things, there are certain washable things, they can decrease the cost. The stress has to be on worker safety because they are our responsibility, and if they stay healthy, there would be less sick leaves. And if this PPE and the worker safety has to stay, the only thing which is the most important now is to train. You might get them the best of the PPEs, but if they are not donning and doffing the PPEs properly, if they're not wearing them properly, if they're not taking adequate personal hygiene and personal precautions properly, everything goes into a waste. It is a time when we invest in the staff to have their health insurances for all those staff members who are not covered by ESI, EPF. We can have insurances for them. There was a very good example from Amritsar where letters were sent to panels, government panels, where and we can send to other panels also where we can request them that whenever there is an operative package for a particular patient, there should be a provision of getting the COVID test, which at the moment in private is costing around 4,500 rupees. There's a provision of getting the test, the payment is done extra. And if some PPEs are bought for that particular procedure, that also should be paid extra. And so these types of letters we can send to our insurance companies and the panels for increased payments of these particular things. One more thing which we have to ultimately think about is that we will be treating patients who are COVID positive. We cannot say no to the elective surgery. We can say no to the emergency surgery. We cannot say no to admission. We cannot say no to the OPDs. But till the time the vaccine is developed or the herd immunity is there, which may take around 18 to 24 months or longer, we need to have some areas in our hospitals segregated in such a way that all the patients who are COVID positive or suspected are treated in area which is separate from non-COVID areas. So this is something which you have to look how you can work in your hospital, because the worst thing for a patient and his confidence of coming to your hospital is that the patient who is a COVID negative patient is lying next to a COVID positive patient, contracts the infection, deteriorates, and then the things are bad. So if you have to not to shake the confidence of the patients and you want them to come to you in the same numbers, you need to have areas designated in your hospital. And this is important as I started from, and this is where I'm ending. The confidence of the patient coming to you should not be shaken. So this is again going to be a thing which is, so now all these COVID tests, these are additional expenditure which we have to bear in these next couple of months. And how we adapt to this new situation in our particular hospital based on these suggestions would be a individual choice. So one of the suggestions is that there are certain things which we can share with our different hospitals, which are our friends, which can be like the certain quality teams, our nursing teams. There can be resource pooling, which we can do with our hospitals so that we can decrease our expenditures, which otherwise would not have been able to do it. But this is the time where I would say that we have to stay united. We don't look at our friend or our colleague as our competitor, and let there be uniformity amongst us. That is what all I have to say about. It was difficult to sum up everything in this shorter time, but I think this is all I have to say about it. Thank you.
Thank you. Naveen, I think has been a absolutely very comprehensive coverage of the entire scenario. I'll have probably difficulty in finding things that I can add on. I was listening to it very carefully. So one of the things that I can try to just augment to what you have said as a strategy. Today, majority of the patients are not coming to you, as you have said. The thing is that you have the database. If possible, you should start connecting with those patients because they are also afraid. They are sitting at home. So this is the time when the hospitals should continue to maintain a contact and a relationship with the patients. That relationship has to be developed in a form that we are there to support you, to help you. You be at home, but you may have some queries. We can try to help it out. So I think there can be an organized way of reaching out to your existing patients, not kind of just waiting for them when things will get up, then they will come back. So I think that can be one way. And also, this is the time, like what demonetization did for promoting digital transaction, this pandemic is doing and will do for digital healthcare. And the community is also getting ready, but both the hospitals and the community has to be prepared for accepting virtual meeting, virtual consultation as a means of providing you good care. So even when things come to normalcy and you wish to avoid the physical contact, I think that issue needs to be started right now. For confidence of workers, you have said enough, but I feel one of the things that the owners should keep in mind, it is the top person has to be seen on the floor himself to infuse the confidence in the healthcare worker. Sometimes I've seen that, for example, an administrator, a senior administrator may be walking with an N95 mask while a nurse or something who is working in the real difficult area is not having that. So that is what will not infuse confidence. You have to develop processes more than ever now to start functioning for almost for everything. And the processes must be developed along with your workers. They should be shared with the workers and they should be developed in consultation with them. And then you have spoken about decreasing of cost. It's a great lot of good things that you have said. I would say two things about that. One is in our experience, energy conservation is one very good area where every hospital can do good to the environment and good to decrease their cost. There is one area where most hospitals we had surveyed, they could reduce significant amount of expenditure on energy conservation. And second, in due course of time, the smaller hospitals and the medium-sized hospitals, I think we need to come together, maybe under the banner, whether under CAHO or something else or any associations, for thinking of bulk buying. You see, the scale of economy is extremely important to bring down the cost. The bigger hospitals have that one very advantage. You will find the same things being available to them at a lesser cost as compared to a small or medium hospital. So we must think of that thing also. And then, of course, I would say quality implementation. I think, let's say this pandemic has taught hand washing like we could never teach to anyone or something. So the issue is this, that the quality has to be implemented now in real terms. And therefore, what you said, train. And therefore, we will say, I will definitely plead with you to see the training programs that CAHO is an organization which is a consortium of hospitals. It's your organization. So what we are doing is that pooling up of our energies, pooling up of our resources. It's a not-for-profit body, and therefore is there to help creating the training programs for you. But overall, a wonderful presentation, Naveen. Congratulations, and I think we can open it for questions. So Kishore, you can take it
Yes,
over and
yes, sir.
pass on.
Thank you, Agrawal sir. The first question, like you already said that there should be the separate arrangement for COVID and the non-COVID patients. And now we can understand that post-COVID, most of the patients will prefer to go in the single occupancy rooms. And kindly suggest that if in small and medium-sized hospitals, how they will tackle, because most of them, they are having the ward pattern. So they should redesign the wards. So what will be the cost and how can we go with this condition?
Kishore, this is a very valid question. Actually, this is something which needs to be individualized. What I would actually suggest is rather than doing many structural changes, they should try to identify different zones. So like if they have got two wards, they can make one ward as COVID ward rather than male and female. They can have one as COVID and one as non-COVID. If they've got rooms on one corridor, half of the rooms with a gate or double gate partition, they can, on one side they can have COVID, on the other side they can have non-COVID. Because they have to individualize for their particular hospital what suits them best. But rather than breaking some walls or adding some walls to make more rooms and compromising the bed strength would not be good. I would rather say you should define zones. For example, so you've got two floors where you've got rooms. One floor you can dedicate for COVID areas and one floor you can dedicate for non-COVID areas. So you should try to first make changes where you do not make much structural changes and income much expenditure.
So next question is like, as the data from the India has shown that the 80% of the COVID patients, they are asymptomatic. And if someone from the surgery patient, should we conduct PCR for COVID as a mandatory investigation or not?
There would be guidelines from the ICMR for this shortly. In many hospitals, what they are doing is they are mandatorily doing a PCR test for all the elective patients. And for emergency patients, they send the sample and they do not wait for the surgery till the time the results are there or not. See, eventually what is going to happen is there is a window period for PCR and sensitivity and specificity for kit tests also whenever they're going to come, detecting the antibodies. Whatever said and done, the patient who is coming to you could be a negative for both of the things, but still could be an asymptomatic carrier because he is in the window period. So eventually you have to change your processes in such a way that you will have to think that every patient is a positive patient till the time the report comes to us or till the time the patient goes back to the hospital. Having the test has got a second bearing also, because now there are many studies which have shown that between patient A and B, if one is a COVID positive patient with a similar comorbid other things and for a similar surgery or for a similar treatment, the morbid outcome is much worse in a patient who is COVID positive than a COVID negative patient. So we'll have to see and treat as if all patients are positive. That is in the present scenario. Maybe in future sometime, if we've got much more accurate tests which are available, that might change the situation.
Right, sir. So next question is from Dr. Kapil. Your comment on the economic slowdown post-COVID will lead to decreased paying capacity by the patients. So how to tackle this? Because we are investing on so many things like PPA, and we are training the patients, and we are separating the wards like that. So if the patient is paying capacity become less, so how to do
The
this?
answer to Dr. Kapil is that, see, that is the reason why this lecture was there, because you are incurring extra cost on PP and all these things.
Right, sir.
If you do not decrease expenditure, you will not be able to maintain at the same cost. I am at the moment saying that the patients are paying the similar amount of money which they were paying before COVID times. So to give treatment in the same charges and not increasing them, you would have to decrease cost at certain other places. That is one. What is going to happen is that the shift towards panel or TPA or insurance patients is going to increase. So in coming few months, we will see that many of the patients from the cash paid patient bulk would shift to the insurance patient in base. So that is going to happen to the patient side. And we cannot ask the patient to pay more. What we can do is that we get every penny working for the patient's benefit.
Thanks. Sir, next question is regarding the social stigma of the COVID patient. Like we're seeing in many newspapers that some hospitals are having the COVID positive patients and they are negatively affecting the other peoples to enter or to go to that clinic. So will it be affecting your clinical practice if you're putting a COVID ward in your hospital? Will it be yes, it
Yes.
is necessary to build the confidence of the patient, but socially, as in Indian society, stigma is much more. So how you
This something is very short-lived. The difference between COVID and non-COVID. As I said, with more and more persons getting infected, whether they are symptomatic or asymptomatic, they are carriers or whatever state they are, you cannot have a situation maybe 6 months, 1 year down the line where you can say that I will not accept a COVID patient or my hospital has no patient but a COVID negative patient. That's point one. Second, see, in coming time, what is going to happen is COVID negativity or your positive antibodies would become a form of a visa. So you apply for a visa to travel to different country, you need to have your COVID status on that. So it is not going to be a stigma in coming times. So at the present times, yes, it is. But with coming times, this is going to change. The number of patients, number of persons getting involved, and for everything, you need to have a security status. So if you are COVID negative or antibody positive, that will be a very good status for you actually in coming times.
Sir, one question from your specialty: how to use a modular OT?
This is actually a very vast topic, but two or three things which we need to take precaution is first to treat every patient as COVID positive patient. So he has to be wheeled in as a COVID positive patient. Ideally, it should be a negative pressure air conditioning which has to be there in operation theater, which in majority of the modular OTs might not be possible. So you have to put your ACs on the positive mode. The disadvantage is that this is going to spread the virus with the aerosols which are generated within the operation theater. So this makes the precautions much more important in the sense that till the time we develop an option of having a negative pressure theater also in our hospital, we need to have two things. First, all your healthcare workers who are entering in the OT should be in their proper gear. Now, we know that the virus enters our body through the mucosa, which is either eyes, nose, or through the mouth. So all those things should be covered. Second is a fomite-borne infection. To prevent that, the healthcare workers who are not scrubbing up, or the anesthesiologists or the floor teams, they should be in their proper suit. The patient, I said, the patient has to be covered while brought in from the pre-op area. The surgeon, he has to take adequate precautions, use the adequate PP so that he is not exposed to the aerosols generated within the hospital, within the operation theater. The main source of generation of aerosols is when the patient is being intubated or when we use some drills, motorized equipment that is going to generate aerosols. Because with the positive pressure of the modular OT around, these aerosols are going to contaminate whole of the atmosphere of the OT. The next precaution that we are going to take, that we should take is that once the patient is wheeled out, we should switch off the AC. We should give some time for the particles, the virus to settle down, do good amount of surface cleaning, and then take the second patient in. And this total process takes some 1.5 to 2 hours between the shifting of two patients. So depending upon the number of OTs available, you have to space your time, the patients accordingly.
Sir, the last question from this discussion: what is your take on the COVID insurance?
take on the
COVID insurance, like
insurance by the patients or by the
patient,
hospital?
by the patients.
See, what my idea is that IRDA has already given instruction that all those patients who are already insured, they have their COVID treatment covered in that. And with the new patients who are taking on to the insurance, of course, whatever be the premium difference earlier or now, they will be covered for COVID. And the same is true for the government schemes also. Like yesterday, I heard the CEO from Ayushman saying that
Yes.
all patients for COVID, the treatment is covered under Ayushman also.
So, sir, thank you very much for this. Your wonderful and very distinctive bit practical issues with the doctors they are facing post-COVID. Thank you very much for your presentation, sir. And over to marketing team to present the vote of thanks.
Thank you, Dr.
Thank you,
Vijay.
sir. Thank you, Vijay, sir.
Thank you. Thank you, everybody.
Over to you, Dolly ma'am.
Yeah, thank you so much, sir. Hello.
Yeah, thank you, Dolly. Thank you for organizing everything in such a beautiful way.
Yes, sir. It's our pleasure. And we thank you everybody for listening, happy listening and learning. And we've got our VP here, Mr. Somikant Bharadwaj. He'll just give a short thanks note to you all.
Hi, Dr. Naveen. It was very nice to hear your talk. It was very structured. Initially, when I was listening to it, it sounded very scary in terms of the way the things are going to come up. And it was very interesting to know things like COVID insurance or maybe your COVID status on your passports. So this thing, this virus is going to leave a permanent mark, and a lot of things are going to change in the future. So we got a very good perspective from it, and also from the hospital setup. I am sure the doctors would have find it very interesting in terms of cost management and other things. So once again, thank you very much, and we look forward for more such interesting topics from you later on.
Thanks a lot.
Thank you, sir.
Thank you.
Thank you.
Thanks all. Thanks, everyone.
Thank you, sir. Thanks.